Welcome, everyone. Happy Wednesday. Well, welcome to the Population Health Collaborative Spring Meeting. I'm Krista Martinez with Constellation Consulting, and we're the convener for the collaborative. Also here from Constellation Consulting is Suzanne Lawson, who'll be assisting us today. The Population Health Collaborative is funded by the New Mexico Department of Health, Heart, Disease, and Stroke Prevention Program. Please note that this meeting is being recorded. Attendees' cameras and microphones are activated today. However, we do ask that you keep your microphones muted. If you need assistance during the session, please enter it into the general chat or message Suzanne directly, and we'll be happy to help you. As we begin today, we will not be doing live introductions, but please feel free to enter your name, role, and organization into the chat to introduce yourselves. Following today's presentation, we will have time for Q&A. You may ask your questions live or post your questions in the chat window. Also, if you would like to make sure that you're added to the collaborative email list, please enter your email address in the chat window or email us directly at info@constellationnm.com. So there's two N's in that email address. So we are pleased to offer continuing education units for community health workers and health education specialists for today's session. At the end of today's session, we will post a link to our session evaluation and CEU requests. If you're attending today's session by phone only, please stay on the call at the end of the session so that we can confirm your contact information. So we're pleased to have Nadia Fazel, Chief Clinical Officer with Albuquerque Health Care for the Homeless. This is really exciting for us. You can read her complete bio at nmhealthequity.org/PHC. Please welcome Nadia.
Hi, everyone. I'm Nadia Fazel. I'm the Chief Clinical Officer at Albuquerque Health Care for the Homeless, and I'm going to be discussing social and structural determinants, how they affect health outcomes. More specifically with our population, we are what's considered a 330H grantee. We are a federally qualified health center that serves exclusively the homeless population in Albuquerque. Our service area is Bernalillo County, so that is where our population comes from. And we pretty much stay within that group of folks. So it's almost entirely unhoused folks. And so we'll go through that a little bit here. I'm going to just share my screen. Okay, so I have you all on different screens. I have my presentation on one, I have my notes on another, and I have everybody's faces on yet another. Because I'm now spoiled with having multiple screens in my office. So I'll try and kind of periodically check if there are questions in the chat or if hands are raised, but I might wait until the end to get there. So, okay. So again, this is predominantly about unhoused folks and the healthcare that they experience and how social and structural determinants affect those health outcomes. So the objectives of this discussion will be understanding social and structural determinants of health, because understanding those differences is going to be important for understanding how health outcomes happen, and learning what a housing first model encompasses, who makes up an interdisciplinary team, and how person-centered healthcare is defined by addressing these determinants of health. So just a little bit of background about our organization. We began in 1985. We opened our doors in a little Silver Bullet camper, and we began outreach services as part of the Robert Wood Johnson and Pew Memorial Trust demonstration project. And Albuquerque was one of 19 cities nationwide to participate in the pilot and develop the HCH model. So we were one of the first inaugural programs to do healthcare for the homeless in the country. So from then until now, the Stuart B. McKinney Act of 1987 established the federal HCH program as part of the Health Center program, the 330 programs, When you have a federally qualified health center, generally those those centers are designed as safety net clinics for just about anyone who can't afford healthcare elsewhere. So they are subsidized by the federal government for general populations who otherwise can't afford healthcare or don't necessarily qualify or live in a state who don't have expanded Medicaid access. That was the goal initially of the 330 programs. What happened from there is that there were separate designees for special populations that additional funding was applied for. So many programs that are 330 programs that are federally qualified health centers have a 330H component to them, where they get additional funding for helping specifically those unhoused folks. We are a sole standing 330H program, which means that we only serve those experiencing homelessness. So we were funded and became a freestanding FQHC and Healthcare for the Homeless project, providing integrated primary medical, dental, behavioral health, and social services through extensive outreach in its central service campus. So basically our model is an on-campus model where we have a centralized clinic, a drop-in center known as a resource center that includes any type of case management or housing navigation, document help, showers, computers, phones, anything that folks kind of need as a resource to be able to use it for whatever they need it for. We also have medical, dental, a pharmacy, psychiatry and behavioral health programs, as well as a harm reduction program with syringe exchange services and an Art Street program, which is what we consider a low barrier place for folks to come and have open studio. We have an art therapist who does therapy sessions there as well. So all of our services are geared entirely towards helping folks get and stay housed. So the dialectal model of homelessness 101, we'll go way back, is structural deficiencies plus personal vulnerabilities that leads folks to tumble through the cracks. And so we are here to kind of be that safety net for those even more vulnerable populations. So let's talk about determinants of health. So there is a very distinct difference between social and structural determinants of health. And I want you all to sort of understand that. And the next slide will break it down a little bit more. The exact numbers of this kind of differ based on the source, but we all know that, only a tiny bit of health in general is influenced by solely clinical care. More of it is influenced by social or economic factors. So this kind of, this chart here kind of breaks down what exactly goes towards folks not having access to healthcare, not being healthy in general. And a lot of it is social and economic factors, health behaviors, physical environment, and a little bit of genes and biology. Clinical care makes up such a tiny amount of that it's really, really important to view the entire whole picture when you're talking about whole person healthcare. So there are other institutions, the judicial system, schools that have produced and maintained modern social inequities as well as health disparities, often along the lines of social categories such as race, class, gender, and sexuality. And a lot of times, these sort of disparities in these institutions are very subversive. They're small. You can't notice them if you're not within them sometimes. And even when you are within them, it's hard to see the bigger picture that you're sort of trapped in this social disparity. So it's really important that as any type of whole health person provider, that you are aware that these systems and institutions and sort of vicious cycles exist, and try and help the whole person based on these issues. So this is an easy breakdown to kind of distinguish between social and structural determinants of health. So what it kind of, and we talk a little bit here about behavioral and biological as well, and which again is a fairly small subset of what makes up a person's healthcare. So you have social, which includes housing, income, employment, physical environment, safety is huge, education, access to healthcare, which is also a really big one, and access to information. And so these are sort of issues that we can have some subset of control over when it comes to organizations like ours. We can help, provide vouchers or, guidance on income and employment. We can help get them to safer environments if they need shelter space or, they're living in their car and we need to help provide some kind of, structure for them to live in and to help guide them to get housing. Access to education, access to healthcare obviously is a big part of what we do, and information in general. So these social determinants of health can often be influenced by those of us in the healthcare industry, as long as we're aware that it goes into the reasons why patients are unhealthy. Structural determinants of health are a lot more difficult to influence as a single entity or a single person. They are things that are not necessarily as easy to influence or to do anything about, but the provider or the person who is managing healthcare of the patient or client should be wholly aware that these are hugely influencing factors when it comes to outcomes. So other examples of structural inequities include a freeway built with limited access for poor urban communities, but easy on-off access in more affluent suburbs. Businesses and jobs that then locate near the freeway exits, which creates a cycle of well-being in the affluent areas and disadvantages in the poorer communities. So when full-service banks choose not to locate in a community, such as an urban area with a high proportion of lower-income residents, payday loan businesses fill the gap, and these are hugely predatory and more expensive and create an ongoing disadvantage for the people in those communities. Another example is grocery stores. In the International District, for example, here in Albuquerque, I had heard a rumor that one of the very last Walmarts that was in the area was closing down, or the Safeway was closing down. If you give folks a lack of access to everyday needs like groceries, then you have everything working against them to become more healthy. So these are things that are very difficult, but the structural pieces of that can be influenced by doing things like policy and advocacy, working in organizations who actively try and change these factors for folks, and provide overall better organizational and structural and big picture sort of systemic changes so that people can have access to care, groceries, banks, things that help sort of improve folks' health. So causes of death, deaths attributed to social factors compared to causes of death, okay? So another way to understand social determinants of health is to look at causes of death, and this was done through a literature review. It's a little bit older. I think the literature review was the articles were published between 1980 and I think the early 2000s, with estimates of relation between social factors and adult all-cause mortality. So the authors calculated summary relative risk estimates of mortality and obtained and used prevalence estimates for each social factor to calculate the population attributable fraction for each factor. So authors then calculated the number of deaths attributed to each social factor in the United States, and here we are. So low education is one of the top sort of attributable social factors that led to death, if that makes sense. So it's not necessarily the cause of death, but it was the biggest attribute that led that person to eventually die. And so a lot of these things aren't necessarily like health concerns. A lot of them are, most of them, many of them are, but a lot of them are these structural issues that have contributed to poor health, which has then led to death. So you're talking about acute myocardial infarction there, which is going to be the highest sort of medical cause of death. But then you have low social support, which then leads to stroke, racial segregation, income inequality, personal poverty, neighborhood poverty. So you have all of these sort of attributable social factors that lead to death that are intertwined into these medical causes of death. And it's very easy to see that there is a huge contributing factors between these structural determinants and actual medical issues. This is a snapshot of our clinic, what we see. I have an amazing data analyst here who, when I ask for one thing, she gives me like 87,000 things. And I'm like, thanks, Jessica. So this might be a little bit overwhelming of a graph, but it kind of breaks down all of our departments and how many patients we've seen that have had a diagnosis with stroke or heart disease. And as you can see, it's declining for us, which is great. I think we as an organization have put even larger of an emphasis on evaluating integrated care and whole person healthcare. So, and you can see that in the numbers. We haven't done any kind of internal studies on this, but the data sort of speaks for itself. And this is just sort of kind of how we track how patients interact on our campus. We like them when they come on site to be, or when they participate in our services, to at least see 2 to 3 areas of what we can offer. That includes any of the categories listed below. But obviously, most of our patients that have these diagnoses have obviously been seen in medical for those said diagnoses. Some in the psychiatry department, and others, our resource center and our Art Street, again, are very low sort of barrier programs. And so that's kind of a snapshot of what our patient population looks like. Here's another kind of very busy chart that I will leave up for a little bit of time so you all can look at, but it is essentially a flow chart of social and structural determinants of health and how that contributes to disease and mortality. So they developed a conceptual framework. It illustrates the connection between social inequalities and health and focuses attention on measures which have not characteristically been within the scope of public health department epidemiology. So most epidemiologists at departments of health look at medical diagnoses and then causes of death, and that's pretty much it. It's really, really important, and what we try to inform our our community partners on is to make sure that they're looking at whole person health. The chief program officer and I do an onboarding for all of our new staff that talks almost entirely about these integrative approaches to working with folks who come from these institutional inequalities and have therefore had really poor access to health. It's a trauma-informed approach because most people who have been unhoused at some point have experienced trauma in some form, and it allows it to be an entirely person-centered approach to care. So this particular flowchart has been formally adopted by the California Department of Public Health as part of their decision-making framework, and it'd be great if others could adopt it as well. And we all know that racism is one of the most powerful structural forces that impacts health outcomes. In this image, you'll see on the right side, the downstream effects of social and structural forces. You will see sort of disease, injury and mortality, and just to the left of that, the individual behaviors such as diet, exercise, substance use, those sorts of things. But all of these things, even behaviors, are downstream outcomes of the upstream forces that impact us. So when you move upstream, you see this box with the living conditions kind of in the middle here. And these are the social determinants of health, if you will. So these are things that some of us can influence, and that the patient or the client can influence themselves. So you have the service environment, economic and work environment, in some cases are more easily influenced. These are conditions in which people are born, they grow, they live, work, and age. But they're influenced by the distribution of money, power, and resources. So health disparities are largely due to the inequitable distribution of these determinants of health. And this inequitable distribution is due to the structural determinants, meaning the forces such as racism, sexism, capitalism, and other social structures within our society influence the social determinants, leading them to be inequitably distributed. So the structures or systems of society, such as finance, housing, transportation, education, social opportunities that are structured in a way that they benefit one population unfairly, is what leads to these sort of downstream issues. So you have risky behaviors, disease and injury, and mortality. And all of this is asking, and all that we generally ask folks to kind of pay attention to is that this is going to affect the way that you manage care for your clients and patients. And to understand that even though you as a person might not be able to fix everything about what's happening here, or even as an organization, we struggle when we do, policy and advocacy work to try and influence folks to think about these, or to change some structures to make it more equitable for folks to move beyond disease and injury or have better access to care. It still is an uphill battle for even us. So the point here is not for you to go out and start campaigning or put signs up or anything like that. It's for you to understand that whole person healthcare includes understanding all of these determinants. So again, this is just sort of another social and structural comparison, and most would agree that a stable residence is a prerequisite for steady employment, children's education, a thriving democratic society. Being unhoused is wholly distracting to a person. If you are unhoused, you are only focused on your own essential survival, and everything else kind of goes by the wayside, and that includes your health care. So a permanent address is required to vote, a consumer's discretionary income, and consumers' discretionary income, what they don't spend on things like housing, fuels a healthy national economy. So again, if you are wholly focused on how to make your rent payments, how you're going to stop living in your car, where you're going to find, your next meal, those are entirely distracting to everything else. And so if you have a permanent address, if you have a income, you tend to spend it on things that you want to do if you have any kind of discretionary income. This leads to healthy national economies and, how sort of the world goes around. So if we can discuss individual level patient advocacy via community health workers, peer support workers, community support workers, for example, that can happen on an individual level and for patient advocacy for each patient individually. So if they're in need of Medicaid benefits in order to access care, or if they're in need of SNAP benefits to get food, these are all things that on a one-on-one level, these folks in any institution or organization can do. The structural component to that is systems level policy change to address barriers to healthcare, housing, et cetera. So essentially, as an organization, we try and straddle this line as best we can. So we have one-on-one folks that work with patients on a daily basis to get them access to whatever needs they need to kind of grow in their lifestyle. And then structurally, we try to lobby for systems level policy changes to address barriers to healthcare. So increased funding, increased access to care, increased staffing, increased clinics, all those types of things, increased access to affordable housing, which is the crux of the reasons why we have such high levels of homelessness, is a structural thing. So for food, you can give, for example, prescriptions for healthy food. We've had some of our providers in the past have been able to write prescriptions so that a third-party entity would pay for the food that patients need in order to live. A structural solution to that would be wage increases and food subsidies. So expanding SNAP benefits, maintaining a livable minimum wage, allows folks to then be able to buy their own food and not have to rely on a provider to prescribe for a healthy food. Again, prescriptions for gym memberships, subscriptions. So that is sort of a one-on-one, one-off solution, but a structural solution would be healthier neighborhoods, sidewalks, lights, parks, healthy and affordable food options. So you can think of, again, social as sort of this one-on-one, where you have vouchers for rideshare services or vouchers for motels. Like, this is a one-off short-term solution, but you can have these larger structural, big picture solutions as well. And so we work towards managing sort of both sides of this. So our housing first model is not new. It is not ours. We did not invent it. It's been around for quite a bit of time. And it is proven to be the best model for housing or for keeping unhoused folks healthy. And what it is an evidence-based philosophy and approach that recognizes housing is a basic human right, and that in order for people to be able to achieve quality of life or pursue personal goals, they must first have a safe, stable place to live. What that means is there are no caveats to allowing somebody to have a house or to have a roof over their heads. It is not our place to say you have to get clean first, you have to get sober first, you have to have a medical checkup first, you have to have a psychiatric evaluation first, you need a behavioral health therapist first. These are all things that in the past historically have been asked of unhoused folks before they can receive housing, which is a huge barrier in and of itself, because if you live in a state that doesn't have Medicaid expansion, how do you expect to be able to afford a medical visit, your prescriptions? How do you expect to get into a program that helps you become sober? How do you expect to, go somewhere and have the abscess cleaned because the syringes that you were using for your substance of choice were dirty? So, all these things are huge barriers to care and therefore barriers to housing. So a housing first model essentially says, scrap all that. We'll give you the house because we know that the house is the biggest proponent to better healthcare outcomes. So as long as you are housed and you feel safe and comfortable, you then feel more empowered to make better healthcare choices for yourself. So again, these are proven models that have happened across the country. Houston is now the most recent and largest city in the country that has made huge sweeping changes, and it's all through a housing first model. And they are really, really moving to make sure that there's affordable housing available for folks, because again, that is the biggest barrier. And then improving health outcomes overall. So the last kind of piece from a medical perspective is we operate with a patient-centered medical home model, PCMH model, if any of you are familiar with that. We are PCMH sort of certified through HRSA, if you can call it that. And that is how we operate with our patient care. So it includes any kind of comprehensive care that the patient needs. This isn't necessarily just medical care, but it includes all aspects of patients' healthcare. We are patient-centered, which means that we are available for patient needs. And it's also allowing the patient to be able to make their own clinical, medical, healthcare decisions. So I'm a dentist. I don't know if I said that in the beginning, but by training, and when I speak to patients, there are always options. And I know that when you go to the dentist, I'm sure many of you have experienced going to the dentist and have them giving you a treatment plan that's like hundreds of dollars, and you don't understand it and you don't want to do it, and it seems super expensive and nothing's hurting you. So why would you? And the important thing to understand is that as a dentist to a population that I serve, and not just in my population, but any patient that I'm seeing, is that choices are always available, and doing nothing is always a choice. So when I present a treatment plan to a patient, it often has more than one choice for a tooth, for example. And again, remember that doing nothing is always a choice. And even though I can give pros and cons, I can give, opinions on what I personally would do with my teeth, it is absolutely under zero circumstances my decision as to what that patient has done. It is wholly their decision as to how they manage their own healthcare, and it's my responsibility as the provider to provide as much information about the choices as possible, and then let them make their own decision about how they want to manage their care. So another piece of that is coordinated care. What that means is that we make sure that internally and externally that we are coordinating with specialists, with other departments internally, to make sure that the patient from a whole picture is taken care of. And that doesn't include, that doesn't necessarily just include medical care either. Again, if I have a patient who is struggling to find food and I know that they possibly would qualify for SNAP benefits, then I will refer them internally to the appropriate person who can help them navigate that. Accessible services, again, we try and be as accessible as possible to patients. We have a combined on-campus and outreach model. So we try and meet people where they are, to use a really often used term, I think, in our industry. And so we go out on outreach to shelter-based outreaches. We go out on street medicine to encampments. We're out there as much as we can, and we try and flex our clinic schedules and our overall organizational schedules to make sure that we are accessible to patients, as accessible as we can be. And then quality and safety, of course, is the last component of that. So our integrated care team, again, we are hugely, and we are proponents of integrated care teams. And that includes, again, not just medical social services, but it includes our pharmacy, our dental team, our art street team, our behavioral health team. It's everybody. It's an approach characterized by a high degree of collaboration and communication amongst health professionals. And please keep in mind that when we say health professionals, I don't just mean medical health professionals. Remember, we're trying to talk about the entire whole person healthcare, and that starts with a whole bunch of things that are not clinical care. And then what makes an integrated healthcare unique is that sharing of information amongst team members related to patient care and the establishment of a comprehensive treatment plan to address the biological, psychological, and social needs of the patient. So again, remember that there is an entire structure for patients that just doesn't include the doctor or the nurse practitioner. Okay, so I want you all to think about who would be on your integrated team. So if you had all of the professionals in the world at your disposal, who would you choose to be on your team? And we're just going to think through some of these questions, and then when we get to the discussion and the case study in the last slide, you'll kind of think through that and how you would respond to this patient's case. So who'd be on your team? What are the goals of the team? Who are you serving? And what are the needs of the patient? Okay, so think about what the goals are for that patient's overall healthcare. Who is that patient that you are serving? Where are they from? How did they get to you? And what are their needs? So what is it that they're looking for from you? Are they looking for medications? Are they looking for housing? Are they looking for a bus pass, back when bus passes were a thing, but buses are free these days, so that's great. And that sort of thing. So think about all encompassing components of integration and how you can utilize that to the best of your ability. Okay, so here is, we'll do an interactive kind of discussion at the end here. And I want you to think about all of the information you're given and all of the information that you still feel like you're missing in order to manage this person's healthcare to the best of your ability. So let's say a 52-year-old male presents to the medical clinic for a provider visit. You know, in whatever profession you all are, think about your aspect and your component of this person's overall healthcare. So the provider diagnoses type 2 diabetes with increased risk of heart disease due to a variety of factors. He has a female partner and 2 children under the age of 18. They're currently living in a 1-bedroom, 1-bathroom apartment. They may be eligible for SNAP benefits, they've never had them before, and Medicaid, and are worried about how they are going to afford his diabetes medications. He has also never had to take medications before, and his partner is worried about how she's going to help him remember to take his medication. So we can do a brief, maybe 5-minute discussion, and please feel free to put things in the chat, which I have not been paying attention to, I'm sorry. We can kind of discuss what your thoughts are, what questions you might have about this person's healthcare, and you know, how would you start to go about managing it from your perspective or your profession? You know, I think we have a combination of, it looks like, social workers, we have folks from La Familia, we have pharmacists. That's great. We've got a huge variety of folks on here. So how can we start from your perspective on managing this patient's healthcare?
So let's go ahead and you can raise your hand, raise the hand in the Zoom, or put your thoughts or comments in the chat. Or physically raise your hand. I'll try and keep an eye out for you as well. We can kind of work through this this conversation.
I think Daniel has his hand up.
Okay. Daniel, go ahead and unmute yourself.
Okay, gotcha. So I work at Healthcare for the Homeless up here in Santa Fe, and we can put him to start off with on the homeless prescription grant to get him the medication immediately as we work towards gaining insurance.
Yeah, so yeah, Healthcare for the Homeless are great. So we don't charge our patients. If they're uninsured, we provide 340B medications for no charge. So yes, that's a great place to start. What about any other healthcare team members that could help you manage this person's healthcare, going, you know, from big picture in the future?
Well, he'd become a patient of ours. We have 2 nurse practitioners here, so it would be a matter of linking him up with one of those as his primary care physician, and then other services like for Medicaid. We're helping him apply for Medicaid here in the clinic.
Great, thank you. We had it in the chat. I'm gonna try and pronounce your name, Ahad, if I pronounce that correctly.
Yeah.
Okay, great. As an evaluator, I want to look at the social determinants of health or structural determinants of health data collected from the patient intake to look at all the different needs. Great, that's great. Yeah, most intakes have a lot of that data already present, and you can kind of evaluate and look at how many folks live in their household, what their income is. As FQHCs, we are required to ask that. And you know, what their race and ethnicity background is and where they're staying. what their address is can also help evaluate the neighborhood. Or if they're unhoused, if they're staying in a shelter, sort of thing.
Great. Any additional comments or thoughts?
Okay. Yeah, so at Healthcare for the Homeless, what we would do here for this patient is essentially we would work, our providers would most likely refer them to our community health workers. We usually have a community health worker embedded in the clinic to be able to provide these sorts of services. And the great thing about community health workers is that they provide, in our organization, an overarching support system from social services all the way up to medical. So they can help this patient get Medicaid and SNAP benefits. They can help him discuss and his partner about how to take the medications, how to help them remember it, how many to take each time. They can go over all the instructions with them and provide other resources and help to actually take those medications. So we work with those types of team members integratively to be able to provide that support. One said, one thing I would make sure to assess is their capacity to engage in telehealth services. That's great. What we do is we have found it challenging in some ways for the unhoused population to participate in telehealth visits for a variety of reasons, mostly because access to reliable cell phone service and minutes can be challenging for them. Most of them don't have their own sort of laptop or tablet device, so it can be challenging. There's also been rumors, especially in New Mexico, that, for example, the behavioral health teletherapy option isn't going to be reimbursable anymore after the public health emergency is over. That has yet to be confirmed that I'm aware of. But there are sort of those types of barriers for telehealth. What we've used for telehealth is we send out like an RN community health worker team to various sites, and then they can facilitate the telehealth visit back to the provider if needed, who is on campus here. So that's kind of a way that we've sort of used telehealth innovatively with the unhoused population, because it can be a challenge. Any other thoughts or questions? I can take the screen down and we can ask questions or talk about other things. One last, this is my contact information. I do best by email, so I didn't even put my office phone number up here because I'm really bad about answering it. So if you have any other questions or you want to talk more about it, or you want any kind of help or anything like that, we're always available for discussions about the population we serve. So that's my email address if you want to reach out and have any questions.
Perfect. Thanks so much, Dr. Fazel. We do have time for Q&A. If you have any questions for Dr. Fazel today, for Nadia, please feel free to unmute yourself and ask your question directly, or enter your question in the chat. And I'll give everybody just kind of a little bit of time to reflect. There was a lot of content.
Hello, I have a question.
Sure. Hi.
Hi, thanks for your presentation. And also, I was a couple minutes late, so if this was something addressed before I got here, just let me know. I'm sorry. But my question is just around, it was really interesting to hear you talk about the SDOH. As I put in the chat, I'm a program evaluator. I evaluate a lot of like social programs related to health. And so SDOH comes up as an indicator that is often collected. Like you said, it can often be in intake forms, and we can often look at that. My question's around, sometimes we see it getting treated more as a input, like that's the social situation or challenge that somebody is facing when they come to services. Sometimes we see it get treated more like an output or an outcome, like organizations will continually measure SDOH and then look at like changes in it. And I was curious what your thoughts are on that, because we've run into a challenge of, it's the determinant, so it's kind of a precondition. It's not the outcome, but often it gets treated that way in terms of what organizations measure.
Yeah, that's really interesting. And I think that's why we push so hard for the understanding between like a structural versus a social. And I feel like I keep hammering at this sort of like dead nail. But what ends up happening is when you evaluate social determinants that are sort of one-on-one smaller influences of health, you can evaluate that as an outcome based on how successful a program is if you wanted to evaluate that. So say I wanted to say how many patients, for example, that I have on Medicaid at any given time. So I say, you know, at this point in time count, I have, you know, I think 50% of our patient population is on Medicaid and 50% are not. And so if I'm evaluating that and then making inferences based on it, then it's something that it should only be used, in my opinion, as a tool for improvement processes within the program. So if I'm trying to track it as like, you know, as an organization, we are making strides into enrolling more qualified folks into Medicaid, and then evaluating that, you know, now 60% of my patients have Medicaid, therefore only, you know, 40% of them fall into this specific, you know, social category. The inference, I don't think, is necessarily fair or appropriate to assign to that group or category based on my work, you know, and what I was able to control. So I would encourage the switch to be about how structural determinants, you know, big picture things like lack of access to grocery stores, has then led to poor health outcomes, and what I as an organization or the you know, the programs that you're evaluating have been able to change that on a smaller scale that has then led to lower, you know, sort of social determinants. Did I make sense there?
Yeah, thank you so much.
Yeah, I just don't think I would use that as, I wouldn't recommend using social determinants themselves, you're right, as inferred outputs from a program. Because if you aren't doing anything as a program about those social determinants, it's an unfair measurement quality. For both the program and the patient, the client, I think.
Perfect, Rose, thanks so much. Would anyone else like to, does anyone else have a question? We still have plenty of time. What looks like the peanut gallery is a little quiet today, Nadia.
It's okay.
No,
good.
Thank you. Thank you so much. Before we finish up today, I want to remind everyone or let everyone know, save the date for the PHC 2023 conference, which will be Wednesday, May 10th from 9 to 1:30. At the CNM Workforce Training Center, and limited stipends are going to be available for registered participants, and you can register at nmhealthequity.org/PHC. I'm just looking at the chat. A lot of folks, great presentation. Thank you, thank you, thank you. Also, as mentioned, we do have our session evaluation and CEU requests for you all today. We've put a link to this in the Google form in the chat, or you can scan the QR code on your screen, and this will take you to a Google form. The evaluation will help us with our QI efforts and also allows you to request your CEUs. If you have any questions or issues in completing the evaluation, please email us at info@constellationnm.com. And again, if you've called in or are unable to follow the link to the QR code, stay on the line. We'll make sure that we're able to help you. Thanks everyone for your attendance today and participation. We look forward to seeing you at the PHC conference. And Nadia, thank you so much. I learned a lot, really separating out the social and the structural. You gave me, I'll be thinking as we wrap this up. Thanks everyone. A special thanks again to Nadia. Have a fantastic day.